Hi, guys.
Hi, Napur. Hi, Dr. Alsati.
Hello, you guys can call me Ghazal.
Well,
So where are you from, Dr. Alsati?
I am originally from Syria and did my medical school in Saudi Arabia and my residency and fellowship here in the States. Yep.
Nice.
okay. All right. So, want to start?
Yeah.
Sure.
Okay. I didn't get time early on to remind everyone, so people will start joining eventually, I think. But, well, doesn't stop us from starting. So, it's 4. So, we did the colon polyps yesterday, and today we are going to start with the colorectal cancer. Adenocarcinoma, characteristic morphology, architectural complexity, that will be cribriform growth, dirty necrosis. Most rise from adenoma carcinoma sequence. Third most common cancer in the US, associated with processed food, obesity, red meat, low fiber diet, and alcohol. Subtypes, although most cancers are not otherwise specified, some subtypes do exist, many of which have distinct morphology, clinical implications, and molecular alterations. So, mucinous adenocarcinoma, more than 50% of the tumor composed of pools or extracellular mucin, most common subtype.
Oh, yeah.
Yeah. So more than 50% of the tumor composed of pools of extracellular mucin, most common subtype. No prognosis implications. Enriched for MSI high tumors. If less than 50%, mucinous features or mucinous component, but not mucinous adenocarcinoma. Signature cell, again, more than 50% of tumor cells have prominent intracytoplasmic mucin displacing the nucleus, has worse outcome, and associated with Lynch syndrome and MSI high. Medullary, sheets of malignant cells with vesicular nuclei, prominent nucleoli, and abundant eosinophilic cytoplasm, prominent inflammatory infiltrate, and BRAF mutations, MSI high, and has a better prognosis. Serrated adenocarcinoma, morphologically similar to serrated polyps.
So I spoke with Dr.
Micropapillary adenocarcinoma. I'm muting everyone. Micropapillary adenocarcinoma, small clusters of tumor cells with stromal retraction, and worse outcome like all organs, like in all organs, and early metastasis to lymph node. Okay. Adenoma like adenocarcinoma, pushing invasion with minimal dysplasia, hard to diagnose on the biopsy, good prognosis. This adenoma like adenocarcinoma is the hardest, I think. Adenosquamous carcinoma. So, and then this is the last one. Okay. So now coming to the grading for NOS cancers. So low grade, gland formation more than 95% is well differentiated. 50 to 95% is moderately differentiated. And high grade, less than 50% is poorly differentiated. Don't include the areas of tumor budding or poorly differentiated clusters. These are counted elsewhere. So based on gland formation in the least differentiated component. Okay. Special data to report. All right. Large venous invasion. So tumor involving endothelial line spaces with an identifiable smooth muscle layer or elastic lamina. Extramucosal venous invasion outside the muscularis propria is a risk factor for liver metastasis. Tumor filling the large vein, destroying the lumen, orphan artery without its paired vein. Okay. Sometimes you must just see the orphan artery and or a large rounded tongue of tumor next to it. So that's how you're going to say that there is an orphan artery and that's the tumor tongue. So that's how you know that that's a venous invasion. The EVG stain can highlight internal elastic lamina of both artery and vein. If you don't see a large venous invasion, consider getting EVG to look for it. Coming to tumor budding. So single cells or small clusters of less than 5 cells at the advancing front of the tumor. High tumor budding is significant risk factor for nodal involvement and poor outcome. Represents epithelial mesenchymal transition. And clusters of more than 5 cells without gland formation, these are the poorly differentiated clusters, and they are associated with worse outcome. Lymph node metastasis must have residual lymphoid tissue, usually rounded contour, and tumor deposits. So basically differentiating between the lymph node metastasis and tumor deposits become challenging sometimes, and they have written nice papers about it. But you should have this important, the residual lymphoid tissue in the cuff, which is important in order to call it lymph node metastasis versus tumor deposit. There are other features as well. The tumor deposit is kind of irregular. If a lymph node is there, then it is more regular, and then with the cuff and everything. Tumor focus in the fat, but without identifiable lymph node tissue, nerve, or vascular structure. Staged as P1, N1C, often irregular contours, and unpaired artery or elastic lamina, large venous invasion. So if there is artery associated, or you can demonstrate that elastic lamina is there, then you should think about the venous. Stages. So stage 0, no evidence of tumor. PTIS is carcinoma in situ, that is high-grade dysplasia, or intramucosal carcinoma involving the lamina propria with no extension to muscular mucosa. Few lymphatics, low risk of metastasis. PT1, tumor invades the submucosa through the muscularis mucosa but not into the muscularis propria. Usually elicits a desmoplastic response, PT1. PT2, tumor invading the muscularis propria. PT3, through the muscularis propria into the pericolorectal tissue. And P4A, through the visceral peritoneum. And then includes gross perforation of the bowel through the tumor and continuous invasion of the tumor through areas of inflammation to the surface of visceral peritoneum. T4B directly invades or adheres to adjacent organs or structures. So in this example, even though the tumor isn't at the surface, because it is continuous with the surface through the inflammation, it is PT4A. Pseudo invasion versus true invasion. So pseudo invasion, usually no or little cytologic architectural adepia, inflamed or fibrotic stroma, hemosiderin-laden macrophages, glands accompanied by lamina propria, rounded, well circumscribed, mostly in the left colon. True invasion, usually cytological or architectural adepia, desmoplastic stroma, infiltrative or irregular growth pattern, not accompanied by the lamina propria, and anywhere in the colon can happen the true invasion. Okay. So coming to molecular, chromosomal instability pathway, non-hypermutated pathway, is nearly 85% of CRC. So basically adenoma carcinoma sequence, large chromosome arm gains or losses, common mutations in APC. First is APC mutation, and then early, so it will be an early phenomena, starts with adenoma, and then activates the WNT pathway, and then others are KRAS and P53. RAS mutations will be seen in 50% of the tumors, resistant to anti-EGFR therapy. That's a very common board question that they ask. Used to treat metastatic CRC. MSI pathway or hypermutated pathway. So these are 15% of the CRCs. And then they are sporadic and they are Lynch associated. The sporadic is BRAF mutation, which will lead to MLH1 promoter hypermethylation, which will lead to inactivation of mismatch repair enzymes, followed by serrated polyp, which will lead to carcinoma. Lynch associated is the germline mutation in the MMR and loss of heterozygosity adenoma, and carcinoma. So lots of mutation, more immunogenic, more inflammatory response to the tumor, better outcome. Also, response to checkpoint inhibitors is also important, anti-PD-L1 drugs. Then third is ultra-mutated pathway. So nearly 3% of CRCs, that is the POLE mutation, DNA replication enzyme. Lots of mistakes with DNA replication and an ultra-mutated tumor. Rectal cancer stuff. For rectal cancers, the quality of surgical technique is key determinant of local recurrence and long-term survival. Grossly assess the completeness of the non-peritonealized mesolectal excision. Score according to the worst area. So basically the mesolectal excision, complete, near complete, or incomplete. Complete is intact, bulky mesorectum with smooth surface, no visible muscle, only very minor irregularities, less than 5 millimeter, no coning, where the specimen tapers dramatically distally. Near complete is minor irregularities which are more than 5 millimeter, moderately bulky mesorectum, and no visible muscle. So muscle, if present, then it should be, if muscularis propria is visible, it is incomplete mesorectal excision and little bulk to the mesorectum. All right. Circumferential resection margin. That is considered positive if the tumor is microscopically less than 1 millimeter from the inked circumferential margin, that is the non-peritonealized margin. All right.
Can I ask a quick question? Hi, this is Kenneth.
Yes, please.
Regarding MLH1 for those sporadic tumors, is there an algorithm to ordering those? I know for MSI, there's an algorithm that you order it basically on every cancer.
I'm not sure if I got your answer correctly. Dr. Alsati, do you get the answer question?
Can you repeat the question again?
Sure. For the MLH, right, for the methylation situation with the MLH1 promoter hypermethylation in a sporadic tumor. Is there an algorithm to ordering that? I know we had a case, I'm a fellow. I know we had a case where we ordered it and I didn't quite understand the logic and when you do.
So, so it was a cancer case?
Correct.
Okay, so it's a cancer case. If it's a cancer case, you order your 4 MSIs, okay? And then let's say MLH1 is lost, as well as the PMS2 or MSH6. So if both of these are lost, then you have to do a BRAF mutation. You send it out for BRAF because there's no way you can tell whether or not it's a sporadic or it's a Lynch, okay? Now, if the BRAF came back mutated, then we're talking about somatic mutation, not a germline mutation. Okay, so that's why you only will send for BRAF if the MLH1 is lost. Okay.
Okay, that makes sense. It's as simple as that. There are no other
no, that's very
okay.
simple. Yeah, because there's no way for you to be 100% sure. So you have to exclude the BRAF mutation. Okay.
Got it.
All right.
Thank you.
Mm-hmm.
But
Anyone else has any questions?
BRAF and MSI are, I mean, like MLH1, PMS2, MSH2, MSH6, these are mutually exclusive, right?
Right. So you have to exclude, no, here's the thing. When BRAF, if you don't have a BRAF mutation at all, then the loss of the MSI, the MLH1, is now linked to a Lynch syndrome. But if the BRAF is not mutated, if the BRAF isn't mutated, that loss is because of hypermethylation. Okay?
Yeah.
All right. So just doing an MLH1 testing is not enough. You have to, if it's lost, you have to do a BRAF after that. So you can confirm which part of the algorithm you will go from there. whether it's a sporadic or a somatic. Okay.
Or instead, I think they do the MLH1 promoter hypermethylation test also. I think it's
Yes,
done
there
with
is
the Mayo
also that
Clinic.
one. There
Yeah.
is also that one. Yes, there is also that one, which you can order right up front. But in my practice, I do it right after doing the MSIs. You're absolutely right.
Yeah.
Mhm.
Dr. Alsati, I had a question, and I have not seen this case. So, and I just saw a report by somebody else. The patient on a biopsy had a like adenocarcinoma, and it was MLH1 PMS2 loss, and they said like workup for Lynch syndrome, and then the physician, like the other pathologist that got the resection for it, and it looked like morphologically it looked very much like medullary carcinoma, like there was a lot of lymphocytic infiltrate around it, and he somehow did call retinal and he called it positive too. Have you seen this kind of, and I haven't seen his case, it's just like from his report, the two reports I just saw.
What did
And
he
I
call
have
positive?
for call retinal was positive, so
Calretinin. Okay.
yeah, so have you seen this, like, and how do you approach it?
No, I haven't seen in this 5 years of practice here at medullary, but yes, for sure, I would if I think about it, I do have other than my CDX2, I'll do a keratin, I'll do a CDX2, I'll do carotinin, and I'll do sometimes even if it's so poorly differentiated, I can also order some GIST markers just to make sure I'm not dealing with an epithelioid GIST. And then from there, I will kind of report my positives and negatives. Because if the tumor does not look purely adenocarcinoma to me, I definitely would throw some markers. And based on the gender of the patient, whether he's a female or a male, I will also go ahead and include prostatic versus breast. Yeah, that's how
No,
I would.
it is definitely like colon origin adeno. It's
Uh-huh.
just like I was thinking, was it just an adeno with the Lynch syndrome, or was it a medullary carcinoma? Like, because these are like two different things. Then.
Oh.
So
And
that was where I was thinking.
was the calretinин diffuse all over the place,
I
or you
have
haven't?
not seen the case. It was
Mm.
recent, and I didn't get to get the
Yeah,
slides and
I
everything.
would definitely, it's based on the calretinin. If it's completely diffuse, I'll definitely be more towards medullary carcinoma. If not, then I will do with medullary features. That's how I would go with that. But I wonder what triggered the clinician to do a calretinin. It seems like there's something that pushed him towards a
So
medullary.
morphologically, like it had so much of lymphoid cuffing around it, and then the cells there was no glandular formation, and it looked very poorly differentiated with so much lymphoid kind of around it. Like, so that's what
Good
like
for him.
that's what he
Good
thought.
for him. Yeah, I would have definitely, that should have definitely came across my mind. But yes, again, if it's no glandular differentiation, because a lot of them can be mixed tumors. If there's no at all glandular differentiation and a well-formed adenocarcinoma parts, then I'll call it poorly differentiated adenocarcinoma consistent with medullary carcinoma. Otherwise, I'll call it a mixed tumor. Yeah.
And then it had like combination was kind of that Lynch, like, you know, MLH1 and
Yes.
PMS2
Yeah,
loss.
lots of TIL.
Medullary usually does not have that. Medullary can have loss, but the combination is different. If I might be missing it. It's either MSH1 and 2. Something is different. Like it's not this combination which is in medullary. It
might be it might have both elements in there. It's what if I were you, I would definitely pull the slides. Is it in the same institute where you're working?
Yeah, it is. Like it was just a last week case, and I just like looking up the reports in the tumor board. So I mean, I'll definitely pull it up, but it's just like we were discussing it. So I just wanted to see like how would you approach it more?
Yeah, no, for sure. Why don't you pull out the slides and send me a message on the side. Let's look into it. That intrigued me. I'm interested about learning more about it. So it'll be nice if we can study it together.
Yeah, sure, definitely.
Okay, sounds good. You still there?
Oh yeah, I was muted. I'm saying if Shweta has a camera, but she doesn't have a camera, I believe she was saying
By
that
end
yesterday.
of this month, I'll get one. I ordered yesterday after your
Good. Which one did you order?
the adapter that you said. I just ordered that, so it will come by October end. So if I get
Okay.
that, then I'll start. I mean, if I think if HIPAA should be fine with if I just identify the cases, I can like show to like if we have time and chance.
Well, the slides
These kind of
are
things.
always de-identified, and
Yeah.
like this everyone does to show the slides. They put their slides on the YouTube and everything. So
Sure.
it's like definitely that can be done. In fact, I was going to ask Dr. Alsati and Dr. Aki if I don't think I actually didn't message him today, but if you or he can pull out some slides, and if you guys have a camera in your microscope, maybe a session of actual slides can be done. Do you have a camera,
sure,
Dr. Alsati?
sure. I don't have a camera, but my friend next door has camera. I might just use her computer or her microscope.
Her
We'll see.
microscope.
Yeah, yeah.
Okay, perfect. It can depend on your time. So because you have to borrow her camera. So when so it will depend on your time, just that it should not be before 8 a.m. over here because people will not be able to attend.
Okay,
so,
sounds good. And I don't know if it might be a weekend session for me because so we'll talk about it.
Yeah. See if you could bring some slides on board. That will be real fun.
Dr. Alsati, if you can bring the one which we don't see usually, like those kind of, even the adenomas which we don't see usually, like the common bread and butter stuff. For the residents, I know like they need the bread and butter, but for people like
no,
me,
even
like
for the residents,
the things like which we haven't seen, like kind of adenomas, like those foveolar adenomas, I have not seen them. So I fear like the thing I have not seen, I'll miss.
Okay.
Do you have any collection that you have written down, like some interesting cases that you have written down?
Yeah, I will. I have few. So I'll definitely make something up and bring them over to share.
Yeah, no rush.
Okay.
Do it at your leisure, and whenever you are available, we can do that.
Okay.
Okay. So then coming to appendiceal lesions. Anyone else has any other questions? Okay. So appendiceal lesions, fibrous obliteration, non-neoplastic benign process, often incidental, replacement of lumen by the fibrous tissue with varying neural proliferation and adipocytes, so may stain with S100. Serrated lesions and polyps. So identical to those of the colon, may be incidental or cause acute appendicitis, associated with KRAS, hyperplastic polyp and sessile serrated. So polyps with serrations of the superficial crypts only and more common, and sessile serrated with distortion extending to the crypt basis, and often circumferential, can develop dysplasia, adenoma-like, high grade or low grade, and then villous growth, eventual possible adenocarcinoma. Coming to adenocarcinoma, so looks like adenocarcinoma of the colon, can be NOS mucinous signet ring, frequent KRAS GNAS, staging very similar to choleric adenocarcinoma, irregular malignant cells infiltrating the stroma, often with a desmoplastic response. Neuroendocrine tumors, most common appendiceal tumor by far, incidence 1% of all appendectomies. Majority of the appendiceal tip, so be sure to sample this, occur at younger age than NET elsewhere in the GIT. Many may present with incidentally with acute appendicitis, has a good prognosis if confined to the appendix, looks and is graded like other GI NETs. See separate guide for details. NETs and cords, nests and cords of cells with monotonous nuclei with salt and pepper chromatin. Then, so unique appendiceal lesions, appendiceal mucinous neoplasm. So basically, low-grade appendiceal mucinous neoplasm, LAM. Villous mucinous epithelium with tall cytoplasmic mucin vacuoles, and low-grade cytology, nuclei compressed to pseudostratified, broad pushing borders with compression of the lamina propria and fibrosis. Mucin may dissect through the wall or with or without the epithelium, and prognosis is very stage dependent. Earlier is much better. Then coming to high-grade appendiceal mucinous neoplasm, similar to LAM, but
The
additionally
LAM,
complex. Go
just
ahead.
one additional point, like for the LAMN, if you see
Mhm.
only mucin outside, it is, you don't have to necessarily see the epithelium in order to upstage the lesion. You just need to see
Right.
mucin.
Right. All right. So high-grade, complex architecture, micropapillary or cribriform, and or cytologic atypia. Infiltrative growth. So that will be definitely adenocarcinoma. Both have frequent KRAS mutations. Both are considered in situ, so PTIS LAM. And if confined by the muscularis propria, if through muscle into the serosa, it is PT3. Okay. If serosa is involved, PT4A. Acellular peritoneal deposits, peritoneum, PM1A. Then cellular peritoneal deposits, it is PM1B. Higher risk of spread or recurrence in pseudomyxoma peritonei. Okay.
I had a small question. So for LAM that are incidentally discovered, per protocol, you need to submit the entire specimen. I just wanted to see what everybody does in case their appendix is a really large specimen and you're looking at 60, 70 blocks. Or has anybody faced that before?
Yeah,
it
you
has
have to submit
completely,
both.
yeah.
Okay.
Someone sent a message on search cyto group. Full job description. All right, goblet cell adenocarcinoma. Previously known as goblet cell carcinoid or adenocarcinoma or goblet cell adenocarcinoma X goblet cell carcinoid. Amphicrine, having both endocrine and exocrine features, with goblet-like mucinous cells, endocrine cells, and Paneth-like cells. Must have at least some low-grade pattern for diagnosis, usually located at the appendiceal tip, staged as an adenocarcinoma. Low-grade pattern and high-grade pattern. Low-grade pattern, tubules and clusters of goblet-like mucinous cells, endocrine and Paneth-like cells with granular eosinophilic cytoplasm, mild nuclear atypia, and no stromal reaction. High-grade pattern, tumor cells infiltrating as single cells, complex anastomosing tubules, cribriform masses or sheets, signature cells, high-grade cytological features, and desmoplastic response. So here is the low-grade pattern, and goblet-like mucinous cells, tubules and clusters, endocrine-like Paneth cells, granular eosinophilic, and mild nuclear atypia. Okay, no stromal reaction. And this is the more high-grade with cribriform-like pattern.
And actually,
All right.
the cases that I've seen in real practice, you don't see so many goblet cells and tubules and clusters. At least the ones that I've commonly seen are just scattered single cells that are just floating somewhere here and there in the muscularis propria. It will have a lot of inflammation also. Do not have a low power acute appendicitis and think that's all it is. No, you have to always go high power and make sure that you don't miss these single goblet cells. I've seen cases, and just giving a tip.
I agree with you highly. I mean, I had one case that it blew my mind off. I could not believe that it ended up to be a goblet cell carcinoid. It was just so unbelievable. I was a fellow at that time. I still have an imprint of that image in my head. And it always comes to me whenever I get an appendiceal orifice biopsy. I'm like, oh my God, I don't want to miss a goblet cell carcinoid. It's just like so, goblet cell, yeah, it's just so subtle.
All right. Does anyone have any other questions? Dr. Alsati, do you have any other experiences that you want to share?
Yeah, I would like to just emphasize about the difference between invasion and pseudo-invasion in the polyps. I will make an effort to find a couple of good cases from my end and share them with you guys. And if I did a slide session, it is very tricky. It's one of those that we most of the time, if myself and my colleague we don't agree on it, we send it out. The one thing I found it very helpful in these is the shape, actually, the very much the shape of those glands coming into the stroma or the stalk. And if I have pointy shapes, I am more in favor of an invasion. And if I have rounded shapes, I am more in favor of a pseudo invasion. Lamina propria is good, but sometimes with a lot of inflammation and hemosiderin-laden macrophages, the whole stalk is so inflamed and we really can't tell. At Hopkins with Montgomery, she had a huge study set, I would say over 200 slides of stuff that was called pseudo invasion, and it turned out to be true invasion and vice versa. And every time I put the slide on the scope, like my jaw drops. I mean, is like, could this be this? Is this this? I mean, until now, it's a very challenging one, and I don't want anybody to take it lightly. Ask around, look around. It will change the diagnosis for the patient because you're asking the patient to either, you're out, first of all, labeling him with adenocarcinoma. Second of all, he might be a little bit more aggressive and he will ask the clinician, even if the margin is negative, to tell him to take the whole colon out. Let's say he's only in his 50s and he has a long life to live. Or on the other hand, you're calling it pseudo invasion, and 2 years down the line, the patient has liver mets. So both ways it's bad, okay? So I just want you not to take it lightly. This is honestly, this one and dysplasia and Barrett's are the most challenging things I face on a daily basis. That's it.
Yeah, that would be very helpful if you could bring some slides.
Yeah,
and,
yeah, I will.
Okay. So anal tumors, benign tumors. First is inflammatory cloacogenic polyp. So non-neoplastic polyp arising at the anal transition zone may involve lower rectum, often anterior, thought to be due to prolapse on a spectrum with solitary rectal ulcer syndrome and rectal prolapse. Surface may include squamous, glandular, or transitional epithelium, which is often hyperplastic, without dysplasia, stromal inflammation, surface ulceration, and granular tissue are often present. Granulation tissue are often present. Classical feature, fibromuscular proliferation around the glands. That's a classical feature. Squamous intraepithelial lesion, non-invasive cytologic and architectural abnormalities of the squamous epithelium associated with HPV. See separate lower anogenital tract, squamous tract guide for additional information. Okay. Then low-grade squamous intraepithelial lesion, also called as AIN1 or condyloma. Cytologic ertypia and mitotic figures in lower 1/3 of the epithelium with associated superficial coilocytic ertypia. Ertypia, hyperchromatic nuclei with irregular nuclear contours. Coilocytes, large superficial cells with large hyperchromatic resinoid nuclei, perinuclear halo, sometimes multinucleated. If papillary exophytic growth, then condyloma, often has marked epithelial thickening, parakeratosis, broad radial pecs, and coilocytic ertypia. Right. High-grade squamous intraepithelial lesion, marked cytological ertypia and superficial mitotic figures, involving full thickness for CIS or AIN3, or up to 2/3 for AIN2. Nuclei are hyperchromatic with irregular nuclear contours, loss of architectural polarity, top looks like bottom, diffuse block positive or of P16. Can screen for anal SIL in high risk populations, for example, HIV positive, with anal pap smears. Coming to fibroepithelial polyps, so anal skin tag, and new non-neoplastic benign polypoid proliferation of anal squamous epithelium with underlying subepithelial connective tissue. Very common, may resemble hemorrhoids clinically. Surface is the squamous epithelium usually, and core is loose fibrovascular connective tissue. May have multinucleated giant cells or fibroblasts with bizarre nuclei and large smushed hyperchromatic nuclei, which are thought to be degenerative, like ancient change in schwannoma, often CD34 positive. If large dilated vascular spaces are there, then consider hemorrhoids. Paget's disease. Pagetoid spread of malignant glandular cells within the squamous epithelium, an in situ lesion, and large pleomorphic cells with abundant base cytoplasm may infiltrate singly or form glandular structures in the squamous epithelium. Clinically, skin is erythematous and itchy. So maybe primary or secondary. Primary derived from the adnexal structures as a apocrine phenotype. So basically they will be CK7 positive, CK20 and CDX2 negative, GCDFP 15 or GATA3 positive. And they're not associated with underlying neoplasm. Now secondary, derived from underlying rectal or anal neoplasm, often rectal adenocarcinoma. Phenotype depends on the underlying malignancy, and they will be CK20 and CDX2 positive. Management must clinically and with IHC evaluate this if this primary or secondary, and exclude the rectal origin. If primary has a strong tendency to recur and can become invasive. Differentials will include melanoma, so do the melanin stains, and squamous cell carcinoma in situ, CK56 positive, block positive for P16. Other benign tumors, so developmental acquired cysts, duplication cyst, tail gut cyst, ectopic breast tissue, hydroadenoma papilliferum. So duplication cyst lined by columnar organized GI epithelium with a well-formed double muscular layer and nerve plexus. Tail gut cyst, retrorectal cyst hematoma, cyst mass near the sacrum, lined by any type of GI tract epithelium, including squamous with disorganized smooth muscle bundles. This is also epidermoid cyst, anal duct cyst, median raphe cyst, mature cystic teratomas, etc. All right, coming to the ectopic breast tissue, this will happen in the milk line, which extends to the perianal area. So you can have ectopic breast tissue over there, and even breast tumors or phylloides tumors can happen. Hydroadenoma papilliferum, well circumscribed nodule with papillary architecture of ducts lined by double layer of epithelial cells with decapitation, secretion, essentially the cutaneous counterpart of breast intraductal papilloma, almost exclusively in the middle-aged woman. All right. Malignant tumors. So if a lesion can be completely visualized with gentle traction of the buttocks, it is considered perianal lesion and not an anal lesion, which is similar to skin lesions on the other part of the body. Carcinomas above the dentate line will metastasize to the perirectal and internal iliac nodes. Carcinoma below the dentate line will metastasize to inguinal and femoral lymph nodes. Coming to squamous cell carcinoma, malignant epithelial tumor derivation from anal squamous mucosa with keratin production, intracellular bridges, and frequent HPV infection. Infiltrating squamous cell clusters and strands with malignant nuclei and eosinophilic cytoplasm. Most common in older patients and women, HPV 90% of the cases, most common type is 16. Risk factors, immunodeficiency, particularly HIV, anal receptive intercourse, and smoking. Histologically heterogeneous, so can have basaloid pattern, marked hyperchromasia, scant cytoplasm, peripheral palisading, reminiscent of basal cell carcinoma, formerly called as cloacogenic carcinoma. Admixed mucin-containing cells. Try to avoid the term mucoepidermoid carcinoma to avoid the confusion. Verrucous carcinoma, bland, well-differentiated thickened epithelium with bulbous exophytic fronts and endophytic pushing invasion, lack the HPV cytopathic effect or significant atypia, cannot diagnose on biopsy, often associated inflammatory infiltrate, locally destructive but does not metastasize. And anal adenocarcinoma. So adenocarcinoma arising in the anal canal and can be extra or intramucosal. So intramucosal arises from the lamina propria and is intestinal type. Extramucosal does not arise from the luminal mucosa, not the lamina. So this one is luminal mucosa, intramucosal, and this one does not arise from the lumina, not in situ component. May be associated with an anal gland, fistula, or other structures. Anal gland adenocarcinoma arise from anal gland or duct. They form infiltrative masses in the wall of the anus. IHC will be CK7 and positive and CK20 and CDX2 negative. Be sure to exclude the metastasis from GYN. Most fistula-associated adenocarcinomas most often arise in setting of Crohn's disease and are mucinous. All types show pagetoid spread and secondary Paget's disease.
Excuse me, I had a question here. Why this anal gland adenocarcinoma should be CK20 CDX2 negative?
So that's what they are writing, right? They are anal gland or duct in origin. So similar to what we had before, that if they are inside the gland or duct, this is the pattern of origin of staining that it has.
Okay. Okay, thank you.
So basically, it's coming from the skin gland, right? So it's not the.
Oh, okay, okay. Like it's.
You got.
Yeah,
you got
I got
that.
it. Yeah, yeah, I got it. Thank you.
All right. Adenocarcinoma involving anal canal. So primary can be mucosal or extramucosal. Okay, mucosal will be more of intestinal type, and the intestinal type will be the one that is CK20 and CDX2 positive. The anal gland, so extramucosal can be three types. So first is anal gland, which will be CK7 positive, 20 and CDX2 negative, with no mucin production. Then fistula associated, that is more of mucin production, and variable depends on the history of fistula. And non-anal gland, non-fistula type, so basically any of these can be anything variable. And then the secondary adenocarcinoma, so involving colorectal metastasis can happen. So definitely that will be intestinal and will have intestinal type features in the staining. True Paget's disease, so apocrine-like, it will look apocrine-like, and it will have the CK7 and GCDF-B15 positive, and CK20 and CDX2 negative. Skin adnexa, that is non-Paget type. So this is a skin adnexal, and again it will be CK7 positive and then CDX2 and CK20 negative. And non-CRC metastasis, this is variable, and everything is variable.
So basically the intramucosal adenocarcinoma, the mucosal origin, before we make the diagnosis, we have to exclude colorectal cancer.
Absolutely.
The absence. I mean, I think we have to mention most likely the patient will not have a history, but I think we should still make note of that as a comment.
Right. We can say that the differential includes either mucosal origin or a secondary tumor arising from colorectal, and they should definitely do.
Always mention, yeah.
Yeah. Okay. Anything to add or any other questions? Dr. Alsati, you have any experiences of this thing?
Yeah, the one thing I had is an experience with that anal adenocarcinoma. the patient had a primary, one case that I had, the patient had a primary colon cancer, rectal origin, and then they had an anal fistula. And then after that, they had an anal nodule. So the anal nodule turned out to be adenocarcinoma. Now, is it part of the original rectal cancer or a fistula arising anal cancer? So we went so much back and forth, but the interesting part of it was the HER2. It was a HER2 negative disease in the rectum, and then it was a HER2 positive in the anal in that anal nodule. So to answer your question right now, I don't know what it ended up being. It wasn't my case, but there was so many similarities and very few differences between the two, and whether to label it this versus that does change the patient's well, the patient passed away, but does change the staging of the patient, does change the whether or not ordering HER2 and treatment plan. So she has two primaries versus one primary with a distant mets. So I wish it was just an easy as let's do stains and figure it out. Sometimes even with when you do the whole thing, you still can't tell.
Right,
That's
especially when you have a concurrent colorectal, that would become such a hard.
Oh yeah, at first, like I think she stayed for 6 months thinking that it was an origin from the rectum and it's a distant met, but then with the anal mucosa and because the fistula, the problem is the fistula, the lining is in the fistula is not squamous only. You will have also lining from the glandular lining. Okay, so which made it even more and more and more complicated at this point. And she refused surgery, so we couldn't.
Sometimes associated dysplasia helps us to figure out if it's a primary or a recurrent.
That's true. Yeah, and if you have a resection, that's much easier. But if you have a tiny biopsy, good luck.
Yeah, exactly.
And can it be treatment related?
Sorry, that's the thing. She had radiation at this area, and she had a little bag attached, colostomy site. So she had many things at this point. So maybe the treatment triggered the initiation of it, but at the end of the day, it turned out to be adenocarcinoma anyway. See what I mean? Like whether it's treatment related or not, she has 2 separate lesions. They are quite separate. They're at least 7 or 8 centimeters apart. One of them is next to a fistula and the other one is up in the rectum. And yeah, she lived with it for 3 years. And I mean, it's still puzzling for me. It's still puzzling for me because I remember the anal biopsy was just the biopsy. At that point, she was so sick to go ahead and do any other surgeries or so forth. So yeah, anal fistulas can be very challenging in patients with colonic carcinoma.
Do you do HER2? I have never heard of HER2 in this location. Do you do it often?
Okay, yes. So lately, a lot of doctors have been ordering PD-L1 and HER2 on adenocarcinomas. Some of them are clinical trials, and some of them is desperate to just try to get it a medication on a patient who are dying. But yeah, we routinely, of course, do it on gastric and esophageal adenocarcinoma.
Yeah,
but
we do
not
it for
routinely.
gastric, but for like anal and rectal, I haven't heard HER2.
I
Like PD-L1 also
agree.
we do, but okay.
I agree. This one in particular, we actually did for it. The patient is a mother of my friend. That's why we were very treating her as a VIP case.
Okay.
All right.
And most of the time, I think the clinicians will request if there is, anything related to that, if there is any therapeutic significance.
Yes, exactly.
All right. So neuroendocrine carcinomas are much more common than the well-differentiated neuroendocrine tumors here. Neuroendocrine carcinomas often arise from non-neuroendocrine tumors and subsequently develop neuroendocrine differentiation. There will be sheet-like growth and they are not graded. Ki67 more than 20% or higher. They are malignant, very metabolically active, rapidly growing. See on normal FDG PET scan. Then molecular SP53 and RB1 and other carcinoma-associated mutations. Platinum-containing chemotherapy. Then small cell neuroendocrine carcinoma, large cell neuroendocrine carcinoma. So small cell morphology, fusiform nuclei, finely granular chromatin, scant cytoplasm, nuclear molding, extensive necrosis, tons of mitosis, and Ki67 almost 100%. Large cell neuroendocrine, large round nuclei, prominent nucleoli, moderate amount of cytoplasm, sheet-like to nested growth. Ki67 is often 60 to 80% of the range. Melanoma, so malignant transformation of melanocytes present in the anal mucosa or transition zone, very rare. Typically old or elderly patients, most common in women. Typically polypoid masses near the dentate line, typically epithelial morphology, large malignant cells with frequent macronucleoli, dusky grayish cytoplasm with frequent pigmentation. IC, the melanocytic markers, molecular BRAF mutations give BRAF inhibitors, and c-KIT mutation give TKI. Poor prognosis. All right. Is that the last one? No, of course not. Okay. You can be with us for the liver as well, right, Dr. Alsati? I mean, do you do liver in your practice too?
Absolutely not. But I
Absolutely.
will attend the liver. I will attend the liver to learn.
It's surprising that you do GI and you don't do liver.
Yeah.
Do
I don't do liver. My fellowship was GI and breast. But yeah, I don't do liver, and I would love to learn it though. So you might see my face here and there.
Do you know of one of your colleagues from GI or someone who may be interested in joining us for liver, who has experience in liver?
I read Dr. Akiki is liver,
Aki,
right?
yeah.
Aki,
Yeah,
sorry.
I think and he said that timings would be hard for him. I didn't actually, I should have told him today's timing is 4, but I was doing like the other work. So, but I think he would be able to join.
For liver. I will ask around if there's someone who's interested in liver. Yeah, not
anyone
me.
Else in the group right now? Like we have 19 people. Anyone else in the group have their like GI liver attendings who can attend for us 4 to 5:30, 4 to 5 or something? Do you have like do we have residence fellows with us? I'm sure we do.
Do you mind repeating the question, Dr.
I'm saying that I'm saying that if anyone knows, like have direct contact with a GI liver, like a liver specialist attending who is doing liver for some time, if you can ask him or her if they can join us 4 to 5 or 4 to 5:30, whatever they can. That for the next sessions, like when the GI ends, maybe this weekend, if at all possible. We may start from liver, starting from next from the Monday. So if they can attend, and if not from Monday because it is very short notice, then from Tuesday or something. But if someone can ask if they have direct contact with a person who does liver, I'll have to see on Twitter. Maybe I can ask someone on Twitter.
Start with Dr. Akhi first.
No, yeah, Dr. Aki, so definitely I'll ask him. And if he's available at 4, then he is there. Then he's the best. And If not, then we'll have to see if someone can come, because as I realized, I mean, everyone else must have realized that having an expert on board makes so much difference.
Okay. I can also be available for cytology if you guys want. It's
Great. Cytology will be our last topic.
okay.
After finishing
Okay.
all the search path, we are going to go to cytology.
Okay, sounds good.
Yeah. All right. So lower anogenital squamous
And
tract.
also for breast, right? You said you did 2 GI and breast, Dr. Alsati. Is that
Yeah,
what you
I
said?
can do breast. I will try my best to be there. I haven't done breast in 4.5 years, maybe 5, but I will. Yeah, but I mean, I do retain some knowledge there, so I have to refresh my memory though. But yeah.
Okay, thank you.
Yeah, I would say, I mean, the residents, and especially the residents and fellows in the group who are associated, like who are not private practicing, like many of us are private practicing too, so we don't have connections with GI pathologists anymore, or any subspecialized pathologist anymore. If you guys have like your attendings who like teaching, like in my residency, there was a couple of attendings who would really like teaching. I can ask them too. But if you have attendings who really like teaching, you know who they are. Ask them if they want to teach to 20 people and maybe potentially more via the YouTube, if they are interested, from 4 to 5. I mean, that will definitely benefit the group. So any of the specialty, we can just book them beforehand. Okay, we can do whenever they are available, like when they are not on service or something like that, and we can modify our schedule based on their availability. All right. So let's continue. Lower anogenital squamous tract. So just keep in mind, I mean, if you have someone, just contact me, and if you want, I can ask them properly by an email, and then we can go forward from there. All right. So lower anogenital squamous tract. Similar terminology is used for all HPV-associated squamous lesions of the lower anogenital. See last project. HPV infection. So type 1, type 2. Type 1 infects epithelium to support virion production that will lead to L-cell condyloma, transient and self-limited. Type 2, viral oncogene overexpression drives the clonal production of undifferentiated cells, and this is more of precancerous H cell type. So low-grade squamous intraepithelial lesion and high-grade squamous intraepithelial lesion, these are whatever in 1, in 2, or in 3, and in 3 is basically in situ. In 1 will be more of coilocytic type. So so for coilocytosis will be present only in ones, and then dysplastic basal cells will be limited to lower 1/3 to 2/3 and full thickness. And P16, so mitosis will be limited to 1/3, 2/3 and full thickness. And P16 will be block positive in case of 2s and block positive in case of 3s. All right. So different abbreviations for different sites. Site abbreviation. So basically, anal intraepithelial neoplasia, perianal intraepithelial neoplasia, penile intraepithelial neoplasia, cervical intraepithelial neoplasia, vaginal intraepithelial neoplasia, and vulvar intraepithelial neoplasia. So vein, ven, sin, pain, pain, ain. Okay. When to use P16 immunohistochemistry? Uses as a surrogate marker of high-risk HPV infection when the morphologic diagnosis is between HSIL, that is P16 positive, and a mimic, such as squamous metaplasia, which will be P16 negative. When we are considering the diagnosis of SIN2 or whatever 2, which should be P16 positive versus LSIL, which will be P16 negative. When there is disagreement between the pathologists, when there is high risk for missed HSIL disease. Like for example, HPV positive. All right, so this is a P16 positive and negative. So positive is strong, diffuse nuclear cytoplasmic block staining along the basal layer going at least 1/3 of the way up. P16 negative, weak to patchy, anything but block positive. Then L cell cytological changes, mature keratinocytes with lots of cytoplasm, having enlarged nuclei, that is 3 times of the normal intermediate cells, irregular nuclear membranes, and hyperchromasia, resinoid nuclei, perinuclear halo, multinucleation. H cell cytologic changes, basically there will be immature keratinocytes, minimal cytoplasm, high NC ratio, irregular nuclear contours, think in 3 dimensions, and increased nuclear size, increased mitosis. HPV is sexually transmitted disease. Serotype 16 and 18 mostly associated with H cell or squamous cell carcinoma. 6 and 11 is L cell and condylomas. HPV associated oncoprotein E6 inactivates P53, E7 inactivates RB. Usually infects transition zone between squamous and glandular mucosa. All right. Mesenchymal tumors of the GIT. No pictures? Okay. All right, so mesenchymal tumors of the GIT, GIST, derived from intestinal cells of Kejer, stains CD117, DOC1, and CD34. Most common, stomach, followed by small bowel. Most often spindled, can be epithelioid or pleomorphic. Mutually exclusive, c-KIT, 80%, or PDGFRA, 10%, receptor tyrosine kinase mutations. Often shrink preoperatively with receptor tyrosine kinase inhibitors, all right, with imatinib, and increased in NF1 patients can estimate risk of progressive disease. See the table at the end of the guide. Okay. And then SDH mutated type. So this will be without a c-KIT mutation. These are pediatric and familiar. And so then they have Carney's statatis syndrome, and they have paraganglioma GIST with germline SDH mutation. Carney's triad is more of somatic SDH, paraganglioma, pulmonary chondroma, and GIST. Epithelioid multinodular metastasized to lymph node. So these SDH mutated ones, they will be more of epithelioid, they will be more of multinodular. They will metastasize to lymph nodes and do not respond to the receptor tyrosine kinase inhibitor therapy. There will be no KIT mutations, but overall more indolent, characterized by loss of SDHB staining. All right. So epithelioid GIST, that is multinodular, metastasizing to the lymph nodes. Think of SDH. All right. Neural origin arise from the myenteric plexus or other nerves. So basically they are schwannoma and mucosal Schwann cell hamartoma, granular cell tumor, perineuroma. So schwannoma, benign nerve sheath tumor with Schwannian differentiation, most common in stomach in muscularis propria. Well differentiated and unencapsulated, spindle cell proliferation with varying cellularity, often have lymphoid cuff with Verroque bodies and hyalinized vessel, often absent, unlike elsewhere. Stains S100 strong and diffuse. Mucosal Schwann cell hamartoma. Small, sporadic, benign, presenting as colon polyp. Uniform bland spindle cells, expanding lamina propria between the crypts and staining S100 positive. Granular cell tumor, benign neoplasm of the neuroectodermal origin, differentiation. Often esophagus, and they are submucosal. Look out for pseudoepitheliomatous hyperplasia, and that will mimic SCC. Epithelioid to spindle cells with abundant eosinophilic granular cytoplasm, highlighted by PASD. Full lysosomes due to inactivating mutations of ADP6AP1 or 2 makes it so can't break down lysosomes. Okay, and that will lead to granular appearance. All right. Stains S100, CD68, inhibin, calretinin. Perineuroma. Benign peripheral nerve sheath tumor composed of cells with perineural differentiation. Typically colonic, small, and solitary. Can be associated with serrated polyps. Bland spindle cells expanding lamina propria and distorting the glands. Stains EMA weak, GLUT1, Claudin1. Ganglioneuroma. Benign neoplasm composed of mature ganglion cells and nerves. Unmyelinated axons with Schwann cells, usually in the colorectum. When multiple or diffuse and or syndrome related, meant to be Cowden NF1, ganglioneuromatosis, usually sporadic, small mucosal polyps detected incidentally. Okay. And then they can have diffuse mural involvement, strongly associated with MEN2B, RET mutation. Stains, so basically Schwann cells will be positive for HUS100. Ganglion cells will be positive for synaptophysin and neurofilament. Gangliocytic paraganglioma, most common in second part of the duodenum, mostly benign, 3 characteristic elements. Epithelioid neuroendocrine cells, think of paraganglioma, ganglion cells, and spindle Schwann cells. Stains, S100 positive in the Schwann cells, synaptophysin in the neuroendocrine cells. Muscle origin. So muscle origin, basically the stains will be desmin, desmon, actin, and negative for neural markers and the GIST markers. So these are leiomyoma and leiomyosarcoma and rhabdomyosarcoma. So leiomyoma, benign smooth muscle tumors, most common in the colorectum, less than 1 centimeter. Polypoid arising from the muscularis mucosa, pedunculated or symptomatic. And esophagus, larger arising from the muscularis propria and symptomatic. So colorectum, they are smaller, arising from muscularis mucosa and asymptomatic, pedunculated. Esophagus, they are larger, arising from the muscularis propria and symptomatic. Bland spindle cells, fascicular architecture, minimal mitotic activity, less than 1 per 50 Haber field, no tumor type necrosis. Leiomyosarcoma, malignant smooth muscle tumors, aggressive. Spindle cell neoplasm with atypia, mitosis, and or necrosis. If multiple smooth muscle tumors in immunosuppressed patient, then you should consider EBV-associated smooth muscle tumor. Rhabdomyosarcoma, malignant tumors with skeletal muscle differentiation, myogenin and MyoD1 positive, multiple subtypes, see small round blue cell tumor guide. Okay. Coming to fibroblastic origin. So fibromatosis, inflammatory fibroid polyp. Fibromatosis, desmoid fibromatosis or mesenteric fibromatosis, most common in small vowel mesentery, usually large. Bland spindle cells, long sweeping fascicles, infiltrative growth, locally aggressive, non-metastasizing. Stains, beta-catenin, nuclear, and may stain with smooth muscle actin. So WNT beta-catenin signaling dysregulation due to somatic CTNNB1 or germline APC mutation. So C with FAB, adenomatous polyposis. Inflammatory fibroid polyp, they are benign, most common in the stomach, proximal duodenum, or ileum. Can cause intussusception. Centered in submucosa, but extend to the mucosa. Plumb to spindle to plump, cytologically bland spindle cell, associated with eosinophils and lymphocytes, often myxoid background. Cells proliferate or circle around the vessels, causing onion skinning. CD34 positive, molecular PDGFRA mutations. Inflammatory myofibroblastic tumor, usually in children and young adults, bland spindle to stellate cells in the myxoid or collagenous stroma with associated lymphoplasmacytic inflammation. Stain, 50% will stain with ALK, which can also be detected by FISH, and variable staining with the myeloid markers. Molecular, 60% have ALK rearrangements, and all can also have ROS1 fusions. Low risk of recurrence, very rare metastasis. SFT, adults with slow growing mass in any anatomical site, and bland ovoid to spindle cells with patternless pattern, episode, staghorn vessels, variable cellularity and collagen, STAT6 and CD34. Molecular, NAB2 STAT6 rearrangement as seen with STAT6 IC. Vascular, so glomus tumor derived from modified smooth muscle cells of perivascular glomus body. Most common will be in stomach, and they are usually benign. Round uniform nuclei with pale eosinophilic polygonal cytoplasm arranged in sheets and nest. Rich vascular hyalinized stroma can be mistaken for NET morphologically. SMA positive in case of glomus tumors. Lymphangioma, benign lymphatic tumor, most common in small intestine, often congenital, presenting in childhood. Thin wall dilated spaces with single layer of endothelial lines, lymphatic spaces containing chylous or serous material. Lymphangiomatosis is multicentric or extensively infiltrating lymphangioma. For lymphangioma, of course, C31 and D240. Hemangioma can be of any origin, benign, but can bleed. Varying morphology or with different caliber vessels, for example, cavernous, should not see any papillary growth, multilayering, cellular atypia, mitosis, and necrosis. Will stain with ERG, CD31 and CD34. Kaposi sarcoma. HHV8 associated vascular neoplasm often occurring in immunocompromised patients, classically AIDS. Infiltrating small irregular vascular channels and fascicles of non-pleomorphic spindle epithelioid cells. Erythrocyte containing clefts and hyaline globules, associated inflammation. Stains 31, 34, ERG, and HHV8 LANA1, often asymptomatic and bleed. Angiosarcoma, malignant vascular tumor of endothelial differentiation, aggressive, often high-grade malignant tumors with nuclear atypia, mitosis, and necrosis can be epithelioid, variably vasoformative, and anastomosing vessels to solid sheet-like growth. Stains, ERG, CD31, 34. Epithelioid angiosarcomas can also stain with CK. Adipocytic differentiation. So lipoma and well-differentiated liposarcoma or a typical lipomatous tumor. So lipoma is benign tumor composed of adipocytes, can occur anywhere. And most common is submucosal lipomas. And if mucosal, think of Cowden syndrome. Well-differentiated liposarcoma or atypical lipomatous tumor. This is malignant adipocytic tumor, often lipoblasts or atypical cells with smushed nuclei in the fibrous septae. MDM2 amplification by FISH should be done. Rare. Plexiform fibromyxoma, synovial sarcoma, gastrointestinal clear cell sarcoma like tumor GNET, or PICOMA, perivascular epithelioid cell tumor. Okay. Okay. So plexiform fibromyxoma, benign tumors that arise in stomach antrum or pylorus. Multinodular, centered in muscularis propria, composed of bland spindle cells in myxoid stroma. Synovial sarcoma, malignant spindle cells, monophasic, possibly with epithelioid to glandular component, biphasic. Uniform spindle cells with almost no matrix and somewhat vesicular nuclei. Characteristics SS18 gene rearrangement and patchy keratin and EMA. Gastrointestinal clear cell sarcoma like tumor, GNET. Malignant sarcoma with neuroectodermal differentiation. Alveolar nested architecture, epithelioid to spindle cells with eosinophilic to clear cytoplasm. Vesicular chromatin, prominent nucleoli, scattered multinucleated giant cells. Stains, S100, HMB45, Milan A, and MITF. FISH, EWSR translocation. Gastrointestinal clearance. Okay. Perivascular epithelioid tumor, PEComa, mostly epithelioid cells with some spindle component. Cytoplasm granular, eosinophilic to clear. Admixed adipocytes, epithelioid cells, and intimately associated thick-walled blood vessels. Variable expression of smooth muscle and melanocytic markers. So basically, HMB45, Melan A, and MITF, and smooth muscle markers. Marked nuclear ATP and mitosis will be a risk for metastatic. It is so boring without the pictures. Basic mesenchymal GI tumor immunohistochemistry panel. Okay, so that sounds interesting. First round, do CD117, DOG1, rule out GIST. Do Desmond, rule out smooth muscle tumors. Do F100.
Just one CD117 and DOG1 are very strongly positive in any STH deficient tumors also. I mean, that it does not always point towards GIST. That's my point.
S100, neural tumors, any other rarer neuroclast tumors. Then after that, nothing comes out, go for second round. EMA, perineuroma, nuclear beta-catenin, fibromatosis, ALK, inflammatory myofibroblastic tumor, Milan A, GNET or PEComa, calretenin, CD68, granular cell tumor, SMA, myofibroblastic or muscle differentiation or glomus, CD31 or ERG, vascular tumors, CD34, vascular, GIST, inflammatory fibroid polyp, and some NF cells. So GIST prognosis depends on size. So there are various groups based on size, mitotic rate, and based on with the location. So gastric GIST versus small intestinal GIST. So they have basically classified based on that. All right. So that is that. Any experiences that you want to share about your spindle cell tumors in the GIT?
So for me and my experience with the spindle cells, bread and butter, first of all, lot of polyps that come out to turn out to be leiomyomas. I honestly don't stain them. I just let them go as just submucosal leiomyoma. Sometimes I give a size if I feel like it. When I get a GIST from a stomach or the small intestine, I do call it spindle cell lesion consistent with spindle cell GIST or whatever. I can straight out call it gastrointestinal stromal tumor, spindle type, because you don't want it to be an epithelioid GIST or so forth. DOG1 and CD117, I'll do that, but I will also throw there a KI. And when I do that, I always tell them that this is just a small biopsy and recommend performing it again on resection specimens. Lastly, I get a lot of FNAs from stomachs and pancreases and duodenums. Those are very, very challenging because GIST does not smear well in the FNAs. I had one last week, I think, and I ended up calling a scant sample with a very focal spindle cell lesion, insufficient for accurate diagnosis. Unfortunately, he has to go back again. But the doctor has very high susceptibility based on ultrasound imaging that this is probably a mural lesion and it's going to end up to be a GIST. My thing to you is with cytology, it's not always easy to make that diagnosis, and don't be shy to ask for more, because a lot will end up happening to the patient based on your diagnosis. He will definitely be staged and full body scan. And if it was a small bowel lesion, it's a worse prognosis for him. So just keep an open mind for asking for more. Don't be shy.
Mhm. All right. Anyone else has any questions here? All right. GI tumor syndromes. So, Lynch syndrome, also known as hereditary non-polyposis colorectal cancer. Germline mutations in the MMR enzymes. Autosomal dominant, defective DNA repair, tons of mutation, they are hypermutated, and microsatellite unstable. Most common form of heritable colorectal cancer. CRC usually develops before 50, often with multiple primaries, nearly 80% lifetime risk. Also at risk for endometrial cancer, upper urinary tract, other GI cancers, and sebaceous skin tumors. Universal screening for all new colorectal cancers. Do the IHC first, which the algorithm has been given. Can also do the MSI testing by PCR. Look for loss of the staining. Normal is intact of all 4 MMR enzymes. Lynch-related CRC is more often right-sided and arises from adenomas. Versus sporadic MMR deficient tumors that come from the SSPs or SSAs and are associated with BRAF mutations, and then MLH1 promoter hypermethylation and MLH1 loss of expression. So universal testing, MMR IHC. So basically MMR intact, probably not a Lynch, it's a sporadic. And then MLH1 deficient with PMS2, then go for BRAF testing. If there is BRAF mutation, then it is sporadic. If there is no BRAF mutation, then go for MLH promoter methylation testing. And if there is methylation, then there is sporadic. If there is no MLH promoter methylation, no methylation, then probably it is Lynch. Next, coming to MS2, MSH2, MSH6, or PMS2 deficient, then it is probably Lynch. And go for germline testing. Okay. All right. Note, DNA polymerase or POL, E and delta mutations can result with similar clinical phenotype. Okay. MMR deficient colorectal carcinomas associated with high-grade mucinous differentiation and lymphoid infiltrates. That is, hypermutated state is immunogenic. Better survival as compared to MMR intact CRC, probably due to host response. Automatically approved for PD-L1 therapy. Okay. So basically MLH1 deficient with PMS2, go for BRAF. If there is no BRAF, go for methylation. If there is no methylation, then it is the Lynch. And then otherwise, so MSH2, MSH6, or PMS2, if they are deficient, then probably Lynch, directly go for germline testing. All right, fuse jiggles. So mutation in STK11 and LKB1 gene on chromosome 19 can be sporadic or inherited. Classical polyps are hamartomas, non-neoplastic, most frequent in the small intestine, can remove with polypectomy. Multilobated may have papillary frond-like surface, arborizing smooth muscles. Generally cytologically bland epithelium, often pedunculated, cause intussusception. Also see mucocutaneous melanotic macules, so lips and oral mucosa. Increased risk of cancers of stomach, colon, pancreas, breast. Ovarian scatats, Sertoli cell tumors, and cervical adenoma. FAP, germline mutation in APC, autosomal dominant, tumor suppressor, leads to lots of lots of tumors. Hundreds of colorectal carcinomas carpeting the colon, mostly on the left side of colon. Almost complete penetrance. Mean age of CRC diagnosis is 40 years. So often prophylactic colectomy in 20s. And also at risk for duodenal and gastric adenomas, less cancer risk though. need to undergo regular surveillance, upper endoscopies also. First morphologic findings is single dysplastic crypts or unicryptal adenoma. Okay. Variants. So attenuated FAP, Gardner's, Turcotte's. Attenuated FAP, less than 100 adenomas, right-sided, older age, CRC. Mutations in different parts of APC gene. Gardner's, FAP with extraintestinal desmoid, osteomas, epidermoid, papillary thyroid carcinomas, classically cribriform morular variant, and nasopharyngeal angiofibromas. Turcotte's, brain tumors, so glioma polyposis syndrome, and usually those are medulloblastoma. MYH-associated polyposis. Autosomal recessive, need biallelic germline mutation for phenotype. MYH gene involved in base excision repair. Defects result in APC or RAS mutations. Multiple adenomas. So this MYH-associated polyposis can have usually less than 100, but multiple adenomas. Extraintestinal manifestations of FAP can be seen. And then there is increased risk of CRC, usually right side, even in the absence of the polyps. MYH-associated polyposis. Okay. Hereditary diffuse gastric cancer. Most common, CDH1 E-cadherin mutation. Autosomal dominant. E-cadherin is important for cell adhesion and tumor suppression. Mutation causes uncontrolled growth of poorly cohesive cells. Many families have other mutations, so we use clinical criteria often. More than 70% risk of gastric cancer by 80 years of age. And endoscopic surveillance is likely inadequate as invisible in situ. Many get prophylactic gastrectomies. And women at increased risk of lobular breast cancer. Classic finding will be signet ring cell carcinoma in situ. Signet ring cells above the basement membrane, pagetoid spread, can progress to invasive diffuse gastric cancer and often multifocal. What other type of tumor has loss of E-cadherin? Yes, lobular breast cancer makes sense, right? Okay. Juvenile polyposis syndrome. So GPs can be sporadic, much more common, especially if few, or hereditary. Defined as more than 5 juvenile polyps or any number of positive family history. Germline mutation in SPAD4 or BMPR1A, present with bleeding, anemia, usually 50 to 200 polyps, and can develop dysplasia and CRC. Age or CRC nearly 35 years and need increased surveillance. Polyps are pedunculated, cystically dilated cysts, and loose edematous inflamed stroma with ulceration. Concrete Canada syndrome. Uncertain etiology, not clearly genetic, non-familial, often older male, 50 years old. Hamartomatous polyp, protein losing enteropathy. There will be diffuse nodular mucosa throughout the GI tract. Broad sessile polyps with edema, cystic dilatations in stomach look like hyperplastic polyp. In colon, they will look like juvenile polyposis. Ectodermal manifestations such as onychodystrophy, alopecia, cataracts, glossitis, and vertigo. Increased risk of colorectal cancer, but PLE is more often dangerous. Protein losing enteropathy. Houghton syndrome. Think of this cow. So uterine cancer, thyroid cancer, and breast cancer. PTEN mutation, autosomal dominant, tumor suppressor, lots of different tumors. Often PTEN syndromes include Banayan-Riley, Ruvalcaba syndrome, or Lermite-Duclos disease. too close. Get, they will have, Cowdens will have hamartomas of mouth and GIT, thyroid carcinomas, usually follicular, breast, high risk, endometrial cancers, multiple MMOmas. What the tricholemomas? Tricholemomas. Lipomas, and then esophageal glycogen acanthosis. Polyps can often resemble hyperplastic polyp in case of stomach. And colon stroma-rich polyps with cystically dilated glands can mimic juvenile polyposis, can contain adipocytes in lamina propria, relatively unique, can get ganglioneuromatous polyps as well. Okay. So is it a hamartoma now? Total algorithm. So polyp with epithelial hyperplasia, dilated distorted glands, lamina propria edema, and chronic inflammation. Does it have a prominent smooth muscle component now? So if it has a prominent smooth muscle component, is it arborizing and smooth muscle widths in the lamina propria with lobular configuration of glands? That would lead to Creutzfeldt's polyp. If not, then are there other cells present, adipocytes and nerves? Then it is most often hamartoma or hyperplasia. Differential diagnosis, hyperplastic inflammatory polyps, juvenile polyps, prolapse polyps, Creutzfeldt's polyps. And so if no adipocytes or nerves, and if there is adipocytes and nerves, then go for Cowden syndrome and or hamartomatous polyp or other P10 syndromes. All right, so no arborizing smooth muscle, no wisp in the lamina propria, no lobular configuration of glands, along with no adipocytes, no nerves, and non-specific hamartoma or hyperplasia. And then again over here. So does not have a prominent smooth muscle component. Are there other cell types? If there are other cell types, then again, it becomes more, think of more of Cowden's and hamartomatous polyp. And then no other cell type. Does the background mucosa show gastritis or intestinal metaplasia? If yes, then most likely hyperplastic polyp or inflammatory polyp. If no, then most likely juvenile or inflammatory polyp. And background is not sampled. Also consider conchoid Kendall syndrome, then hamartoma hyperplasia. Okay. So ganglion cells and nerves, adipocytes, either of these, think of Cowden syndrome. Can confirm there are adipocytes and not air with S100. All right, so that's that. There's only one remaining, I think, just the GI and neuroendocrine tumors. Let's see how big that is. Just 3 pages. So we'll finish this and then we'll call it a day. Anyone has any questions for so far the reading? Okay. GI neuroendocrine tumors. So neuroendocrine tumors, neuro, contain secretory granules like synaptic vesicles. Endocrine, secrete peptides and amines locally. Tumors can arise anywhere in the GIT. They have characteristic morphology and protein expression. Immunohistochemical markers. Note, these may also recognize neurons and neuroblastic cells. So synaptophysin and chromogranin recognize the dense core granules. CD56 and NSC is less specific. Often dot-like perinuclear staining with cytokeratin or enzym 1. New and E neuroendocrine transcription factor, which has a nuclear staining. So with cytokeratin dot-like staining, and then enzym 1 is the newer ones. All right. Then coming to types, so well-differentiated neuroendocrine tumors, also known as carcinoid, and poorly differentiated neuroendocrine tumors, mixed neuroendocrine, non-neuroendocrine tumors. So poorly well-differentiated, uniform round nuclei, salt pepper, fine speckled chromatin, granular cytoplasm, organoid or nested cords, glands, rosettes, or ribbons, no necrosis, variable stroma, can see amyloid deposition. Molecular, MEN1, DAX, ATRX mutations common. particularly in the pancreas. Malignant but slow growing, indolent progression. Early NETs have low risk of metastasis. Somatostatin receptors can detect with DOTA PET radiographically. I don't know what this DOTA is. Graded 1 to 3 based on Ki67 or mitosis. That will be in the next page. All right. Polydifferentiated. So often arise from non-neuroendocrine tumors and subsequently develop neuroendocrine differentiation. So they will have sheet-like growth, non-graded, not graded, malignant, very metabolically active and rapidly growing. The same slide is that mutations P53 and RB1, treatment platinum containing. So again, the small cell and the large cell. So we already read this slide. Mixed neuroendocrine and non-neuroendocrine neoplasms, menin. So a neuroendocrine tumor or carcinoma with non-neuroendocrine component, both should be more than 30% of the tumor. Can be adenocarcinoma, squamous cell carcinoma, anything. Presumed to be clonally related. A non-neuroendocrine carcinoma dedifferentiates and transdifferentiates to a neuroendocrine carcinoma. So most common sites of these neuroendocrine tumors, most of them are carcinoids, and neuroendocrine tumors overall are relatively rare. In GIT, they are often polypoid and centered in the submucosa or muscle with intact overlying mucosa. Small intestine is most common site, often in the ileum. Tend to present later with advanced disease, either liver metastasis or large lymph node metastasis at the root of mesentery. Appendix, often small and incidental. Rectum and stomach, 3 distinct settings, types, see separate stomach duct. And then pancreas, arise in the pancreatic parenchyma from islets, grow into peripancreatic fat, or less commonly into the pancreatic duct. So the classification is based on the Ki proliferation index and mitotic index. And so basically, well differentiated, grade 1, 2, and 3, and poorly differentiated, small and large cell. Well differentiated, grade 1, 2, and 3, less than 3%, 3 to 20%, and more than 20% Ki67. Mitosis, less than 2 to 20, more than 20. Poorly differentiated, more than 20 of Ki67, more than 20 of mitotic index. So site of origin, NET metastasis with unknown primary. We can do a panel of stains to try locating the primary. Also, clinicians can do DOTA PET. All right, don't know what that is, DOTA PET. CDX2, small intestine. TTF1, lung. IL1, pancreas or rectum. SADB2, rectum. Ki67 proliferation index based on evaluation of more than 500 cells in a hotspot. Mitotic count based on evaluating 50 high power field, but reported per 10 high power field. Variants. So cystic, almost most neuroendocrine tumors are solid. Some, particularly in pancreas, can undergo central cystic degeneration. Pleomorphic nuclei can be there. So endocrine atypia seen in endocrine organs can be seen in well-differentiated neuroendocrine tumors. These changes appears to be degenerative and are not associated with high Ki67 and have no prognostic importance. Oncocytic, abundant oncocytic granular cytoplasm with eccentric nuclei appearing rhabdoid can have pleomorphic nuclei. Somatostatinoma can be often ampullary with glandular appearance and somomatous calcifications. Can be mistaken for adenocarcinoma. Clear cytoplasm associated with Eppel-Lindau. Lipid rich, lots of lipid vacuoles. Adenoma carcinoid. Rarely, small neuroendocrine clusters are found incidentally next to an adenoma in a polypectomy. The neuroendocrine proliferation is typically small and possibly reactive to the tumor milieu. Coming to tumor syndromes. So functioning, hormone secreting characteristic syndrome. Functioning tumors are pancreatic, often pancreatic and discovered sooner due to symptoms. Non-functioning tumors are often discovered later with metastasis or incidentally. So basically insuloma, gastrinoma, VIPoma, glucagonoma, stomatostatinoma, and carcinoid syndrome. So we don't need to read all of those, we know like the features. Family syndromes, so MEN1, neurofibromatosis 1, von Hippel-Lindau, and tuberous sclerosis. So MEN1, majority develop NETs, and pancreas, the MEN1 will have more of pancreatic NETs than stomach or duodenal, often multifocal proliferation of islet cells with microadenoma, and well-differentiated neuroendocrine. Okay. All right, I'm tired and I don't want to read this anymore. Tuberous sclerosis, also angiomyolipoma, hamartomas. Von Hippel-Lindau can have well-differentiated NET with clear cells. Hemangioblastomas, clear cell renal cell carcinoma, adrenal tumors. NF1, risk of well-differentiated NETs like neurofibromas and PNS digest, okay? Addition to other lots of tumors, and particularly ampullary stomatostatinoma. All right, done with Kurt's notes GIT. So for tomorrow, we are going to do the slides. Yay! pathpresenter.net, not secure, back to safety, advanced. What the hell? Pathpresenter.net.
It sometimes happens if you switch
Do,
the browser.
do you mind sending the link for the
Yeah.
for tomorrow's topic via the WhatsApp group? Just want to take a look at the cases.
Yeah. So
oh yeah, that's
I'll
it.
send,
You're showing it now. Mm-hmm.
Yeah. So that's the pathpresenter.net. If you go to pathpresenter.net, and once you are there, go to high yield cases. So basically, I'll go again. So just go to pathpresenter.net, and there you go to high yield cases. Once you are in the high yield cases, we are going to do all of these systems eventually. But first, we are doing the GI right now, and enter. So again, they will say, I don't know why it comes twice. So enter, and then there are like 50 cases in the GI that we are going to discuss, and we'll see if we need like both Saturday and Sunday to do these 50 slides, or depending on what is our pace and everything. I don't think they have a lot of descriptions in here. Like for example, let's open one of these. So this one, basically what we are going to do is we are going to scan all the slides and see what's going on, and if we can say what's going on. So we'll see the graph.
Does the case info give the history?
The case info does not give history. Sometimes it does give history, but most often you'll just have the slide and you're going to diagnose it. The case info will give you the diagnosis. So over here, so again, this is Crohn's.
No, Akanksha, I think there is a mode you can set where you can just get the clinical.
Yeah. Yeah, so I have to explore. There are different modes in the pathpresenter, and when I was talking to Dr. Raj Singh, he sent me links to different kind of modes that you can set, and like not modes, there are different kind of settings that can be done. I'll have to play with it. Maybe we can have better user experience, but this is what we got. So we have the diagnosis, and then the microscopic features. We have whatever granuloma formation and the other fissuring and everything. And then
and if
there
you
is
click the green one, then it's actually, I think it points as to where that feature is on the slide.
yeah, right. So this will give you the glandular disarray and then the granuloma formation. So this will give you that. And then so some of the systems, like depends on who has written the content, who has collected the content. Some of the systems, there is a lot of description, there is a lot of clinical history and everything is given as well. But some of the systems, there's not a lot. So it might be fast if we do 2 hours tomorrow. So we are planning to do 7 to 9 your time. So that will be 10 to 12 our time, like EST time, right?
Yes, that's
Dr.
perfect.
Sati.
I'll set my alarm. Yes, I will set my alarm.
Sorry, I am making you wake up at 7.
No, actually, my pleasure. I would love to be around.
And I would say to people, don't try to see those slides, because try to be them like unknowns for you. What I can do to make it more fun is bring your laptops rather than your mobiles. And once you have your laptops in your hands, I can give you a remote control, and we can take turns looking at slides, and like giving a slide to a particular person. They go and have fun with that slide, everyone looking at that slide, and let's see if they are or others are going to diagnose it. That way we can do, or else the other way is obviously that I can monitor, or like I can do all the slides, like travel through all the slides, and we together try to make a diagnosis. So anything can be done. If like I suspect that many people will not have laptops still, so I would think that that would be the situation, that I'm going to go through all the slides, and then we are going to see the diagnosis. So that's a plan. If we are done tomorrow, then we can take Sunday as a break, depending, or else we can go ahead and do the ebooks, surgical pathology review. So if we are done with those 50 slides tomorrow itself, then we are going to go into Sunday. We can also do the stuff that we did not discuss somehow, if anything that is extra in here. So these all things are the same: papilloma, granular cell tumor, diverticular, webs and rings, reflux esophagitis, Barrett's esophagus, eosinophilic achalasia. So we have covered malarial-wise. So what we can do is we can go through these pictures as well. Like looking at the pictures is always fun. And whatever pictures they have given, we can go through them. And if any topic is still left, we can study that. Like some of the cytological pictures are there. Or we can just skip this book and take a break. So depending on what everyone wants to do. There are certain things that might be helpful, certain quick points that might be helpful from the book. We can devote 2 hours to reading some specific highlighted important points of the book. All right. Okay.
Thank you.
All right, see you guys tomorrow.
Yeah, see you tomorrow. Sorry, I have to
Okay,
make you wake up at 7.
No, don't
All
worry
right.
about it. All right, take care.
So 9 to 12:30 tomorrow?
Your CST will be 9 to 9.
Eight,
CST will be 9 to 11. For EST, it will be 10 to 12. And for
Okay.
Pacific time, it will be 7 to 9.
Okay, awesome. Thank you, Akanksha.
All right.
Thanks,
Okay.
everyone.
Thank you, everyone, for joining. Thank you.